Welcome everyone to day 2 of Virtual Wish 2020. One of the most exciting and dynamic fields in healthcare today is immunotherapy, with numerous recent clinical breakthroughs. How can the full potential of these be realised? It's the subject of one of this year's Wish reports and of this forum panel discussion.
I am Kirsty Wark and welcome to this session, Realising the Promise of Immunotherapy, and it's sponsored by Qatar Biobank. I'm delighted that you are joining us wherever you are in the world, whether you're in Aberdeen or you're in Christchurch, wherever you are, we're delighted you're on board and we want you very much to be part of this panel, not just listening, but also sending in your own questions as well, wherever you are in the world. This is a truly fantastic vision for the future. And I really think this panel will stimulate new ideas and solutions. Immunotherapy can revolutionize treatment for an array of conditions, for cancers, for Alzheimer's, for arthritis, many more. But the report promotes a vision of bringing immunotherapy to countries and people across the globe, not just rich ones, low and middle income countries too. And the report shows new ways of working, collaborations, and is also peppered with stories of immunotherapy breakthroughs, like Ricky's story, like Emily's story, Margot's story. And we're delighted that leading the panel will be the report's author, that is Professor Gillian Griffiths. She's Professor of Immunology and Cell Biology at Cambridge University. She's led her own research programs at Stanford, at Basel Institute for Immunology, at UCL, at Oxford, at Cambridge, and she's been recognised many times over for her groundbreaking work. Delighted also to have Professor Mary Gospodovich, University Professor at the University of Toronto. She was appointed as Officer of the Order of Canada in 2015. Her research focused on clinical trials evaluating radiation therapy, image-guided precision therapy, cancer survivorship, and more recently, global cancer control. Her Royal Highness, Princess Dina Mired, is the mother of a cancer survivor and the current immediate past president of the Union for International Cancer Control, the first Arab to be elected to this crucial leadership position. Her Royal Highness established and led all the core work of the King Hussein Cancer Foundation for 14 years until 2016. Dr. Jackson Oram is the Executive Director of the Uganda Cancer Institute, highlighted in the report as serving East Africa, Rwanda, Burundi, Kenya, Tanzania, South Sudan, and Uganda. As a medical oncologist, he is leading the development of several international collaborations with renowned international cancer centers and institutions for infrastructure, for human resources, and actually for capacity development as well. But last but not least, Dr. Ian Fowkes, who began his career as a research scientist, completing his PhD at the Cancer Research UK Beatson Institute. Now as CEO of Cancer Research Technology, He's responsible for ensuring that research is developed and commercialized, often in partnership with biotech and pharmaceutical companies, to ensure the fruits of that research reaches patients rapidly and effectively wherever they are, in whatever they are in the world, in low-income, middle-income, and high-income countries. So thank you all to the panel for joining us. And before we start our discussion, here is Professor Gillian Griffiths with her overview of the report.
Hello, my name is Gillian Griffiths, and I am a Professor of Immunology at the University of Cambridge. It's been my privilege to chair a panel of international experts, all of whom have contributed to this WISH report on immunotherapy. Recent successes in immunotherapy have led to remarkable breakthroughs in cancer treatments, making this one of the most exciting and dynamic fields in medical research and biopharma. With an expanding range of applications for immunotherapies, including autoimmunity and infectious diseases such as COVID-19, it's become clear that we're really only at the very beginning of a wave of innovation that will have a remarkable impact in improving human health worldwide. But of course, with unrivaled opportunities come great challenges. And the aim of this report has been to identify those challenges and to draw up a series of recommendations for governments and policymakers that will enable them to catalyze the discovery, the development, and the delivery of immunotherapies worldwide. In the report, we identified 4 key pillars which offered opportunities for maximizing the impact of immunotherapies. These included focusing on basic and translational research, opportunities in the development and delivery of infrastructure, opportunities to improve clinical trial innovation, and opportunities, of course, to improve patient access. Based on these challenges, we developed a series of recommendations that aim to illustrate how governments and policymakers could easily catalyze the discovery, the development, and the delivery of immunotherapies globally. These range from supporting discovery science and facilitating the translation of academic research, to reducing infrastructure for cell therapies and establishing centers of excellence in order to attract trials to new parts of the globe, to support collaborative trials, and to create frameworks for the use of observational data, and finally for delivery to the patients to enable experimentation with novel pricing and payment methods, as well as developing national health strategies for immunotherapies. So in summary, we think that by realizing the potential of immunotherapies, it will have a positive impact on the health and well-being of millions of citizens across the world. Thank you.
Gillian, thank you very much for that. And now with our panel, and remember, everybody who's watching, wherever you are, in 20 minutes' time, we would love you to join us with your questions, so don't hold back. Ian Fowkes, first of all, a broader question about immunotherapy for you first, before we start. You know, when people fundraise for cancer, and they fundraise, and people understand that it's about chemotherapy, it's about radiotherapy, but immunotherapy is not so well known. And at the same time, I suppose with chemotherapy, you can have almost generic drugs, whereas the whole point about immunotherapy, it's targeted incredibly closely to the patient. How do you sell that as something that's affordable for everybody?
Yeah, thanks, Kirsty. I mean, firstly, I think it's a really great report. And you're right. I think immunotherapy has really come along in the last sort of 5 or 10 years as a critical new pillar of cancer treatment. We've got radiotherapy, surgery, chemotherapy. This is genuinely a new approach, and we're really only just at the beginning of this. You know, there's an awful lot more that we need to understand. I think because we are quite early on in the process, you know, we've developed a few successful therapies and a few successful approaches. There's still a long way to go. So we're in this kind of real innovation phase at the moment, and you know that does bring quite a high degree of cost. I think we should have confidence, though, that as we've seen with chemotherapy over time, we'll see the costs come down as we improve the technology, as we improve the way in which we can distribute this. And the report touches on some of the challenges of that. This is an incredibly expensive therapy. It's very precise. Now, where that I think gives us a benefit is we should be able to see and identify those people who really can benefit versus those who perhaps can't. We don't need to give them that expensive therapy. And that's a critical thing we'll need to understand, is who's going to benefit and who's not, and therefore direct the therapy at them and reduce the costs accordingly.
And the collaborations in order to be able to fund this properly are vital so that you can do these clinical trials. Yeah. And I wonder when everybody is, as it were, strapped for money, what is your big USP? What is the thing that you're saying to people? Okay, you have to put a lot of money into these collaborations, but in the end, it's going to be better for everybody.
Yeah, it is. And I think we have to sort of, buy into this philosophy that, innovation like this is expensive. It isn't cheap to develop these kind of new therapies. There's a huge amount of basic discovery science that goes in at the beginning. Industry has to step in and develop those drugs, and that does, cost significant amounts of money. But when we see the real benefits that the report touches on, these are some extraordinary improvements in mortality and survival. Yeah. And I think we've got to work with health systems around the world, with industry, to come up with new ways and innovative ways of pricing these drugs based on outcomes, for example, as opposed to just a generic price for everyone.
Yeah. Gillian, just to go into one example in your report, which I thought was very telling, and it was the story of Emily. And basically, her treatment with conventional cancer drugs had really come to the end of its possibilities. And her family stumbled, essentially, upon an immunotherapy trial that she could be involved in. Are we still at that stage that it's so little known in a way that it is very much potluck?
Oh, well, I think there's many. I think what is improving enormously is the public awareness of what's available. And so while Emily's parents had to, when she was diagnosed, really make great efforts to find out what was possible. I mean, the number of trials that are going ahead now it's doubled in a year. It's taking off at a phenomenal rate. There's also many more therapies coming out and being used for many more different types of cancer. So I think that the greater knowledge, the greater availability, it's still not commonplace, and it still has to be sought out. But I think it's becoming much easier.
And as Ian was saying, the outcomes are so terrific.
Yeah.
That what you want to do is, how do you get people to get involved in that early stage science and fund that early stage science?
Yeah. So I think that the answer to that's immediately obvious if you begin to describe how scientific discoveries takes place. So, for example, if you think of the really transformative scientific discoveries that have led to enormous medical breakthroughs, if you look into what the scientists, what they were actually trying to do, they were trying to understand the minute details of the science underlying a particular system, such as the immune system. Mm-hmm. So, for example, I could illustrate this. So I immediately can think of three important discoveries that impact upon immunotherapy in particular, all of which were so important they were awarded Nobel Prizes.
Can you just tell us very briefly, in layman's terms, what they were?
I can indeed, yes. So the first is Cesar Milstein and George Kuller discovered monoclonal antibodies, which are now the medicine of antibody, of immunotherapy, if you like. And the reason that Milstein did this work was because he wanted to look and see what an antibody looked like in real detail. And so he wanted to make a very, very pure product. And then, of course, once he had done that, once he'd made that discovery, he realized, well, if you have this, you could begin to use it to treat different diseases if you have particular antibodies. Another one very closely related is Jim Allison made use of one of these monoclonal antibodies to combat cancer directly. But the reason he was doing his research is because he wanted to understand how a T cell works. And so it's the antibodies and the T cells that we hear about now that are really at the heart of immunotherapies working.
So that's two, and I'll just keep two with you, because I know that you worked with Milstein. I mean, that was terrific. That was, imagine working on those programs. But the developmental pathways, is it fair to say, and I want to come on later and talk to Dr. Oram about this, fair to say, are these developmental pathways going to be restricted to countries that can afford those, or is there going to be research all over the world?
Well, I think that we would hope that the research will be all over the world, and that the technologies are becoming simpler and more transferable, if you like. But I think perhaps this is something that Dr. Oren will speak to in rather more detail. I think from my perspective, one of the most important things to helping funders, in fact, helping the public understand why the fundamental science is so important is to raise public awareness of the process of scientific discoveries and to let them share in the understanding of and the excitement of the discoveries. And I think, if I may, one of the positives that's come out of the pandemic with COVID-19 is there's been much better awareness. So now every school child, every old age pensioner understands what a virus is and why you need an immune response. And
the other thing that's come out of that, funnily enough, is how old structures are broken down and how quickly, because they have to have collaboration, that collaborations happen.
Exactly. And so everything has become, I mean, it's one of the strengths is that because we had this urgency, that many more of the studies, many more of the trials have become much, much more collaborative, and in order to get the data out there. So from the point of view of immunotherapy, the pandemic has in some ways done us a bit of a favor, because now everybody understands the basics of what's required. And it's the antibodies and the T cells that both really the fundamentals of immunotherapy, as well as the fundamentals of what will cure the COVID-19.
Professor Gospodarovich, I wonder if you see the benefits in a funny way like that of COVID-19, that you see changes in attitudes, changes in working practices.
Yes, it's very interesting what has happened. We've had many initiatives trying to increase the use of information communication technologies, virtual care for 20 years, and there was no uptake. And suddenly with the COVID pandemic, everybody does virtual clinics. Most patients who don't have to come to the hospitals are looked after at home. We moved a lot of treatments to outpatient basis, and all these initiatives that we wanted to implement for decades suddenly happened. They happened overnight. So it just shows you that we can do it if we want to, and if there's motivation. And I want to echo what's being said about collaboration. It's amazing how not only collaboration locally or in the country, but how the collaboration internationally has strengthened. And the flow of information is so much faster now that people are hungry to learn about COVID, this new disease that we are all learning about at the same time.
But how can investment into immunotherapy benefit health systems and the wider treatment ecosystem? By that, I mean helping to justify allocating limited resources when it is a relatively young field.
I can think of at least 3 or 4 ways that immunotherapy would benefit the whole cancer ecosystem. First of all, one of the main problems with access to cancer treatment is lack of trained professionals, lack of personnel. And the implementation of immunotherapy requires a cadre of people with skills, with current knowledge and information. So by implementing newer treatments, you actually increase the capacity of most countries, not only to do immunotherapy, but to do all other cancer treatments by attracting well-qualified people to work. The other...
I interrupted you. Carry on, sorry.
The other thing is that it is a new field, as being said, and it's field in evolution. There's a lot of research to be done. So most centers who provide immunotherapy are engaged in clinical research and clinical trials. And it is well known that engagement in clinical trials improves the quality of treatment for all cancers and for all modalities. So just the fact that you must engage in clinical trials will improve quality and it's good motivator for engaging in newer treatments such as immunotherapy.
It's funny because where I live very near to the Beatson Institute in Glasgow. And people who I know who have cancer that could possibly be treated by immunotherapy, who are offered trials, now don't hesitate. I think that's what's it, that there's no hesitation now about taking part in any immunotherapy trial, because I think people are now understanding and I know it's happened to a couple of friends of mine, the benefit has been absolutely phenomenal. Which brings me on to Dr. Oram, because the very thing about the high-skilled, high-trained, and it's expensive, and when you have limited resources, what does the Uganda Cancer Institute do? What is the main way that you can operate in terms of collaborations, in terms of government funding? I think you're still muted, Dr. Oram. That's it.
Thank you. Yeah, thank you very much. I think this report has been a fantastic work, and I want to really congratulate Professor Griffith for leading this team so well and coming up with a report that also take into consideration the needs of people who are in the low and middle income countries that in most cases actually takes years before they can gain the benefit of new innovations like immunotherapy. So I think at the Uganda Cancer Institute, or in Uganda in general, one of the advantages that we have had is that we have kind of made diseases that are complex like cancers to be at the forefront of research. And as a result of that, clinical trials or use of new agents is not very new in our setting, despite the fact that we are in a low or a low-income country. So I think we do see that with the coming up of immunotherapy, we are going to transform the culture. In most of the developing countries, the culture is that things pertaining to treatment are ready-made. That means that the drugs, they come already made for a particular purpose, and that is it. And for that reason, that culture kind of prevents the use of new technologies as they come. It takes years, about 20 years before new technology can actually come on place in a setting like what we have most of the developing countries like Africa.
But it's interesting because of the very things that I'm interested, you're saying it takes about 20 years, but I wonder if you think now, because of, for example, the pandemic and because of breaking down of barriers and so forth, that actually progress might come more quickly for low and middle income countries.
Precisely. So I think really there has to be really a change of mindset, a change of ways of doing things. And this cannot come easy until there are policies that actually can allow these changes to kind of very, very easily be transformed into a day-to-day way of doing things. So I think that the treatment like the immunotherapy that we are talking about should actually be brought to the front so that policymakers begin to know that, you know, we are in a global community. What is good for the communities in the developed countries can actually be also good for the communities in the developing countries. And in particular, when we are talking about complex diseases like cancers, you know, there is no way we are going to wait for so many years before we can treat patients in Africa, for instance, with modern treatment like what we have in immunotherapy. We have to do it right away.
And I know that one of the critical things that you have worked on and have been a pioneer on is the whole culture of safety in healthcare in lower and middle income countries. So how do we ensure going forward with immunotherapy that exists?
That's a great question. So I think really the most important thing that needs to happen is actually the change in the culture. And with that should actually come the next thing, putting at the forefront research. Research should not be looked at as a preserve of the developed world. And the low and middle income countries should not be looked at as just beneficiaries of ready-made research. Research must be done right here and now. We must be part of that. So I think that is the most important thing that has to take place. My colleague mentioned about clinical trials. The terminology of clinical trials should become commonplace in our setting in the developing countries.
Thank you very much. Your Royal Highness, I mean, the Union of International Cancer Control, you have got regional engagement strategy and capacity building efforts, just speaking exactly to what Dr. Orom's been talking about.
Yes, of course, local and regional engagements are key. You know, we've done, when I was president of UICC, I'm now the immediate past president. We've done all the global advocacy, we've done all we can. WHO came up with all the tools, but we realized that ultimately you need local and regional action on the ground for you to see a change. With regards to immunotherapy, and after listening to all the distinguished colleagues, I want to pick up from a few points. First of all, having read about the Ugandan Cancer Society, it was very heartening to see how actually the research culture in Uganda started really at the heels of having to deal with one disease, which is Burkitt's lymphoma. And I like that, and I think countries should take note of that, because sometimes it's so overwhelming to think of having to start from zero to launch a whole new infrastructure for cancer research. And then one disease helps you start to pave the way for that. And I like that story, and I hope cervical cancer elimination, for example, could be an engine and a push for low middle income countries, for example, to be able to forge improved cancer care. So you always have that one engine that can help you do that. And I like that story from the Ugandan story. Then listening from all of you, you're all, like you said, there were so many stories from Emily and other patient stories that I loved in the report, by the way. Thank you so much, Professor Gillian, to put the human factor in that. But, many of us in low middle income countries, we do not have access to clinical trials. It's not easy. And I want to say, you say that there is that excuse, some low middle income countries, they don't have the infrastructure. But for example, at the King Hussein Cancer Center, and I know Mary knows the center very well, we have an amazing partnership and collaboration with Princess Margaret Hospital, the best partnership that we have. A real one, I would say, and that's honestly big thanks to Mary as well to make it very real. We have the infrastructure for immunotherapy, and we did ask a certain institution that we have a big partnership, not Princess Margaret, to give us access to their clinical trials, and it was impossible. So again, I think low middle income countries, yes, political leaders, they have to start somewhere to put a strategy for immunotherapy, because I think you have to start from somewhere, but also the global health community have to also be serious in opening the door to low middle income countries. And like Professor Jackson said, reduce the time for it to reach our shores, work on the sort of low-cost solutions, having the solidarity approach that we saw with COVID-19. There are things that we have to do, but there are also things that have to also not just be words from the global community.
I'm interested, Your Royal Highness, in what you're saying. Just unpack for me a wee bit about that refusal to grant there, because that's really interesting.
Yeah, I mean, I know they said, can we have access to your clinical trials? They said, no, difficult. That was as simple as that. And even though they know we are a top cancer center, we are internationally accredited, we have specialized labs, we have review boards, etc. I mean, we're quite up there, and it's not easy. So again, as we speak now, even normal clinical trials, we are completely disenfranchised from that as low middle income countries.
That's so interesting. I wish we had some kind of big government person here as well that we could put this to. But we've got Gillian Griffiths. Can I just have a response to you about that? Because if this is going to be true, the whole agenda is about leveling generally. If that's the case, then surely, apart from anything else, as well as the benefits, the load has to be spread.
Absolutely. And I think one of the points that's already been raised is there's a different distribution geographically of which cancers are prevalent in which countries. And so actually the whole world has a lot to learn from having more collaborative trials. And I mean, we were able to find some examples of where this was taking place, but clearly it sounds as though it's a policy problem that this is not taking place. Is that correct?
Your Royal Highness, policy problem, do you think?
I don't know. It's like we're so used to from low middle income countries to, fight for our credibility, and it's like that was quite a shock actually.
But let me put that first of all, Jill, let me put that to Professor Gosparovich. You were nodding your head there when Her Royal Highness was speaking. Is there genuinely an issue about trustability or the willingness to let go from these original senses of excellence to create other senses of excellence in low and middle income countries?
I think it started as that, but it's now the regulation. We all live within our own regulatory worlds. And I remember early on, about 30, 40 years ago, we weren't allowed to do clinical trials with Europe because it was somewhere else in Canada. It was there were barriers, regulatory barriers. But those barriers are being eliminated now during COVID because there is need for global collaboration. There is need for including thousands of patients on trials all over the world. So I think we should take advantage of the disruption that COVID has created in this whole regulatory framework to say, if you can do it for COVID, you can do it for other things and other diseases. And one very unrecognized factor is that we are all, we all have our legacy systems, whether it's UK, Canada, US, the rest of Europe, and it's very difficult to change the way we're doing things. And the low and the middle income countries, because they don't have this legacy system, they can actually leapfrog and innovate. And it's probably easier to imagine new ways of doing research with less, difficulties.
Entrenched.
And we can learn from those countries. And that's still not being recognized very much in Europe and North America, that actually we can learn faster by collaborating.
Yeah. Let me ask Ian Fowkes about that. I mean, in terms of ring fencing money, I mean, I suppose your funders, when you put people together, they want certain parts of work to be done in certain places. And is that a kind of barrier to this idea of moving towards fewer legacy countries doing most stuff?
Yeah, I think it is a bit complex. I mean, my organisation's a charity. It's 99% of the money's raised in the UK. Needless to say, a lot of the donors would expect the research to take place, therefore, in the UK. I think what we have to do as an organisation is convey the narrative that it doesn't have to be that. It's about funding excellence, and actually, I think, as Mary said, it benefits the UK, it benefits other countries if you have this real sort of rich ecosystem of research. And I think what Dr. Oram said as well is really important, that if we can create these research hubs, it has a sort of positive feedback effect, that you start to build the research culture, you build a training and capability. The big industry players, the big pharma players see, therefore, that hub as a place that you can get a trial done effectively. Yeah. And I do think, we do have to, keep talking about COVID, but I think it's important. My organization, we have about 200 trials underway at any one time. Those trials take 18 months to 2 years to set up, normally, a cancer trial. With COVID, we're setting trials up in 4 to 6 weeks. And we've got to ask ourselves as a system, how can we do that? And, it's made easier because everything else stops. But there's something about the way, whether it's the regulation, whether it's the process, that we can really do this much more quickly and therefore more cheaply.
That is fascinating, though, that if 90% of your donors are in the UK, then they want work to be done in the UK, which is, in a way, it's very antithetical to a global view of what's best for us all. Who's to say that a treatment not done in Burundi on a particular kind of cancer through immunotherapy is not going to benefit somebody in Iceland. I mean, it seems such a narrow pathway.
Yeah. It is. I mean, it is, and but partly because we've got to tell that story more effectively. I think, though, we've heard as well that, you know, for many patients with these very experimental therapies, this often is a sort of final line of therapy. They've exhausted other technologies. So, you know, there is that sort of sense around how do we benefit from, you know, people on clinical trials. But, you know, we've got to just convey this story that you know, a rich cancer research ecosystem globally, the diversity of thinking that brings will benefit us all at the end of the day.
Dr. Oram, you must understand very well this idea of legacy systems and how you need to break that down. And is it that you've got just to do a great advertising job? I mean, how are you going to break those systems down so that the great work you're doing attracts money from all over the world?
That is really, I would say, a dilemma that we need to break. It is I would call it a cultural dilemma, because there are so many examples of contribution from research from the developing countries that actually had an impact globally and also actually benefited quite a lot the developed world. Just like Princess said about a cancer called Burkitt's lymphoma that was discovered in Uganda more than 50 years ago, turned out to be a cancer that was very responsive to chemotherapy. And about 50 years ago, mind you, chemotherapy was an experimental treatment, just like most of the immunotherapy now. And then that led to the National Cancer Institute to transfer part of its operations in as far as clinical trials are concerned to where the theater is. That was in Uganda. And that led to the birth of the Uganda Cancer Institute. The impact of those research were transferred back to the United States. Yeah. And I can get that there is no cancer center in the world now which doesn't use some of the principles that actually came out of the research that was done in Uganda 50 years ago now.
Well, I think this is a very good point to pause for a second and welcome questions from our audience all over the world. And now, happy to take many questions, and they're coming in. And I've got a question, first of all, from Lua Al-Sheikh, which actually really could be directed to you, Ian Fowkes. How does immunotherapy fit in the framework of precision medicine?
Yeah, I mean, I'm sure Gillian and others will have a view on this one as well. I think centrally, in many ways, I think what we're seeing with some immunotherapies, not all, but with some, is exquisitely personalized. You know, these are therapies designed to an individual patient and an individual patient's tumor, and you know, often that's why we see them to be so successful. It is unfortunately also why they're very expensive, because you're making a medicine for every single person and their unique cancer. But I think it's a paradigm that's here. We've got to get to grips with it. You know, this is where the science has taken us to. Every patient is different. Every tumor is different, and there's huge variety within every tumor within a patient. So, in many ways,
and the idea is, sorry, it just strikes me the idea that you know, you can't design individually because it's going to be so expensive. Is the other side of that is if you design individually, it'll become less expensive as people do not need to be cared for so long, and their recovery rates are better. So it's just a different, Your All Highness, a different mindset we need to get people into about immunotherapy.
Yeah, I mean, the thing is, I think the overall framework, I think, it's about inequity.
Yeah.
You know, are we going to have these special designer drugs for for high income countries and nothing for low middle income countries? Are we going to keep saying to a patient in Africa or in another low middle income country, listen, the miracle drug for you, you know, after you've done all your normal treatment and there is a chance for you to use a last resort, an immunotherapy clinical trial, it is there, but unfortunately not for you.
Yeah.
Are we going to keep that inequity? So that is really, I would say, one issue. And countries do need a leg up. After all, the global health system, in the past, with the sort of focusing on the dichotomy between infectious versus non-infectious diseases, that has led to so many low middle income countries to actually be delayed in setting up the infrastructure for cancer. They do need a leg up. I know we don't have a global fund like HIV, and people are so scared to talk about that, but countries do need a leg up. And I really feel, especially now with COVID, unmasking so many realities that or issues that we've been calling for, we need to take that into account. How long are we going to create a new gap, which absolutely we will not be able to bridge? It's just not right. Before I just go to something else, I just want to concur with Professor Jackson also. It's so important to, like you said, for policymakers to start thinking about immunotherapy, and also to concur with Professor Mary, because yes, it does take time to get the right human resources for immunotherapy on the ground. I mean, I've been to countries only now introducing radiotherapy machines, and they don't have the radiotherapists. Yeah. So you need to start the seed with that, even if you still can't deliver immunotherapy. And I want to say this is so important for low middle income countries in terms of reversing the brain drain as well.
Yeah. Yes,
and so important.
Yeah. Let me bring in Professor Gospodarovic. You want to come in there before? I've got lots of lovely questions in, and I want to take lots, but you want to come in on that, Professor Gospodarovic?
I think that in many instances, when people talk about global cancer control and population benefits, they think that you need to start with screening, early detection, very simple treatments, because that will benefit most people. And you should leave immunotherapy behind because it still benefits very few people. But I think that what we believe in is the diagonal approach, where you can scale up the research and the complex treatments that benefit individuals. So don't just benefit population, but at the same time, introduce the policies and treatments such as universal health coverage and screening and prevention and public health interventions that benefit larger population. So if you do the vertical, benefit the individual, give the best possible treatment to individual at the same time as expand population-based initiative, then you can move forward much faster than just leave the complex treatments behind for a decade or two until you scale up the access to care.
Thank you. I've got a question now for Dr. Oram. And this comes from Galia Al-Hai. And it's on that same vein about how we make advanced immunotherapies more accessible to the average cancer patient, if there is such a thing as an average cancer patient.
Well, I think one unique thing about cancer is that just like COVID now, it's really a global disease in the sense that you cannot say that the way you are going to treat cancer in Africa or the protocol you are going to use in Africa is going to be very different from the protocol that you are going to be using in the developed world. And for that matter, that means that actually we cannot talk of an average cancer patient. Globally, it is the same thing. So what that means is that, as we said earlier, there is need for us to bring this treatment nearer to the people, nearer to the average African, for that matter. And
what can I ask you about that? What Professor Griffiths was talking about earlier was designing innovative payment models.
Right. Actually, that now brings the crux of the matter, because in all this, actually, what stands in the way of access to most of our patients is the finances. And given that, most of our people are unable to afford this, there is need for us to have policies or our governmental systems that allow the public to actually access this treatment. Because If you are going to ask them to pay, they are not going to. And that brings in another aspect that I think Princess Dina also alluded to. Most of these treatments are not going to be in Africa. For that matter, that means most of the patients who are in Africa or in the developing world are going to move to where those treatments are. And it is not going to be the average patient. It's going to be the elite. And the elite have control of resources. So for that matter, that means when they move out to go and get treatment outside of their countries, they're going to move with those resources. And it's going to
they're going to move these resources, and also the expertise. You know,
absolutely.
When Her Royal Highness was talking about lack of radiotherapists at one point, you want the expertise to be within your country.
Absolutely. Actually, that is actually one of the aspects. There is need for us to develop the capacity, to develop the infrastructure, to have the expertise within the country. And that brings me to another very important point that actually our countries within Africa need to begin thinking about pulling together their resources by establishing their centers of excellence. A country like Uganda or Kenya or Tanzania may not have all the resources that it requires to set up, for instance, a state-of-the-art radiotherapy center. But they can pull their resources together. And actually, this can make access to such advanced treatment actually nearer. And I think in this case, centers of excellence might be the way to go. And for the East African countries, which comprises about 5 or 6 countries now, they have actually thought about that. For cancer, they have set up the East Africa Center of Excellence for Cancer. And this is actually going to be a very good base for us to scale up treatment like immunotherapy.
And Professor Griffiths, just coming to you on that question, because it's in the report as well, that the unique payment models, I find it really weird to think about payment by results, but tell me, that's a very crude way of putting it.
So yes, so what we've tried to illustrate are there's a diversity of payment models, and so I think one of the goals of the report is really to try and for example in the centers of excellence that Dr. Jackson just talked about, is that to make them more attractive for trials to be done there, and for pharma globally to become engaged in many more countries than they perhaps limit their studies to at the moment, so that also to make different therapies more accessible. But of course, we all recognize that payment for some of these treatments, particularly, for example, if you think about gene therapy, can be quite substantial. And so there has to be more creativity, more innovation, more thinking outside the box in how can we come up with different ways so that the patients can benefit. Because with all of these type of things, the more patients that can benefit, the costs come down. I mean, it's been shown.
And the expertise grows. And the expertise grows. And that's the other thing. Now, there is another question here from Galia Al-Hal. And Ian, coming back to you on this one, which you have addressed to a certain extent, but a specific question now, an interrelationship between developments in cancer research and COVID-19.
Yeah, I think there are two. I think one is this whole thing around infrastructure, speed of trial, telemedicine. All of that has really forced us to think very hard about how quickly and efficiently we can get trials done. And that's going to lower the cost, because if you can treat patients at home, if you can do follow-ups at home rather than bringing them into the clinic, all of that takes less time, takes the cost down. So I think there's a whole piece around COVID and the system for cancer trials and cancer studies we need to learn from. I think then there's, and probably Gillian or Mary are better placed, but then there's a whole piece around the biology of COVID. Now, obviously, we heard news last week about this potential mRNA vaccine that BioNTech and Pfizer had come up with. We've been studying mRNA vaccines in cancer for a while now. BioNTech have got a vaccine in trial for melanoma, a type of skin cancer. And again, we've seen great proof of concept coming through with COVID. So I think there's an awful lot around the basic science, the basic biology of immune systems that we can learn from each other. And we've been trying to drive collaborations with immunologists who sit across these different disease areas, because they're understanding the immune system, which has an impact on everything. And I think again the report calls for more of that kind of basic discovery science. And we've seen it with COVID. we'll see these vaccines being put to play in cancer as well. And I think that's exciting.
Professor Griffiths, one for you now. Is back to this idea of exciting funders and decision makers. This is particularly relevant now, says this questioner, when we need to ensure continued support of basic science when much attention is being diverted to emergency responses.
So I think that what I said earlier is very relevant here, that it's about improving the public understanding of science and improving the public understanding of what it takes to get a medical breakthrough. That it's really remarkable discoveries in the science. I was trying to think of an analogy for you. It's you have to do an experiment to try and look at the details. So all of the Nobel laureates that I mentioned earlier, and even this year's Nobel laureate, Emmanuelle Charpentier, made a point that she was trying to discover the absolute details of how a bacteria fights off infection. But actually what she uncovered, which she wouldn't have realized until she'd done all of her experiments, was that she found a mechanism for making tiny changes in genes that will be really invaluable in gene therapy, for example. And so to get the funders excited, you have to embed in our educational system an understanding of how scientific discoveries are made. So have education focus much more on learning about how scientific discoveries happen rather than just rote learning what has already been discovered. And so that can be, from the earliest schools to much more public awareness. And actually, we've seen it with the COVID-19 that the public's awareness of immunology is already there. In some ways, the pandemic has catalyzed some of the of the importance of the immune response. And luckily for us in immunotherapy, it's actually the same components of the immune response that are going to that are required to combat cancers as well as the COVID-19. So I think it's allowing everybody at all levels to share in the understanding of what's required to make the science go forward, and also to enjoy the excitement. I mean, you've seen the excitement of when the latest vaccine trials are announced, that people realize here's something that's generating an immune response, and this is going to help us all. So I think that's really important.
If one continues this vein of thought, the cancer has been thought of as a complex adaptive system. And people think the fact that we need to have system thinking to conquer cancer. And COVID is also a complex adaptive system. And I think people now realize that in order to deal with COVID pandemic, you not only need improvements in healthcare, but many other industries, in governance, in government's response, in funding, in distribution of resources and procurement. So I think that, and this is not new, there's been lots written about systems thinking for healthcare and for other systems in the past. We just haven't implemented. And this gap in implementations of what we know, I think, is costing lives all over the world.
I am here. I hope you can hear me. I'm trying to join the meeting right now. I think I was cut off, so I'm terribly sorry if I was. Here's a question from Faraz Almir. How much potential is there for the centres of research to be shifted away from developed countries since the regulatory barriers are now being broken down? Do you think the extent of the COVID developments will spill out into other medical areas? And do you think they'll be replicated, or do you think people will go back into their silos?
So I will. I think that there's been an enormous learning curve where there's been much better collaboration. This is what I meant when I said actually many of the recommendations we've made have sort of been catalyzed by the pandemic, that you have more sharing in many clinical trials, or more collaboration, more uniformity, in order the WHO has led a number of trials where it's gone across the board and you're able to compare more medicines and deliver them more rapidly to more people. And so I think that the learning is there. I think also, and this is maybe something that our colleagues such as Dr. Oren might want to comment on, is there's much better communication remotely, such as we are at the moment. And that has become a kind of accepted norm this year. So I think all of these things will help.
Let me put a question now to Ian Fowkes from Faras Almere. And in fact, it's to everybody. So how much potential is there for the centres of research to be shifted away from developed countries since the regulatory barriers break down? We've done that one, but Ali Kanan, with the emergence of superbugs like MRSA and other bacteria and viruses that have become resistant to most conventional forms of therapy, how does the panel see the role of immunotherapy in fighting those microbes? Professor Gospodarovich.
It's a difficult question. I think that certainly the antimicrobial resistance is another huge area where global action is necessary, and where improvement in practice and stopping abuse of antibiotics in many jurisdictions is needed. Mm-hmm. Yes, there will be new infections, there will be new viruses, there will be new disasters, but I think we are learning how to deal with them. And I think one thing that this COVID pandemic has created is realizations of the value of health. Yes. And the fact is that if you ignore healthcare, public health, it's going to cost you dearly. And the whole world is paying for that right now, and will continue to pay probably for many, many years because of the impact of this pandemic on the economy. So I think if we don't forget the impact of health on the economy and avoid what Princess Dina was talking about, this false dichotomy. It's not economy versus health or health versus economy, it's both. So I think that I don't think that we can just count on people not going back. There needs to be an action, a prospective action to solidify the learnings from the COVID pandemic and change our systems, not only health system, but other systems as well.
Your Royal Highness, you were talking, you raised the possibility, you were talking about HIV, the global response to HIV, and you were looking at this, I think, as a template for how we could move forward with immunotherapy.
Yeah, I just wanted to say that we really don't want to follow the beginning of the HIV/AIDS, where we were all in chaos, right? And the prices were high, and they were not made accessible. The medicines were not made accessible to those who really bear the brunt of the burden until finally they decided. I think India started to make their own and unilaterally started to produce their own drugs, and the patients, advocated very strongly. Then the prices went down, and so on and so forth, and we started. The HIV issue started to be dealt with properly. But again, they also had like a global fund for AIDS, and so that sort of focused all, it made the collaborations possible from the funders, from the countries, from the research, which is what we don't have for non-communicable diseases. That's the problem. But I want to say that we don't have a luxury, actually, of going back to our silos anymore. Like Professor Mary said, now we're so under-resourced. We are barely going to, already we're going to predict so many more cancer deaths, simply because of the destructive effect of COVID-19, the extra focus that went on it, taking resources and attention to it, delay in diagnosis, early detection, treatment, etc. So we need to really go back to fundamentals. I think this is what COVID-19 really brought home. I mean, we've always been calling for, all these issues that we saw with COVID, lack of accessibility, lack of medicines, equipment, etc., has really been the daily lot of low middle income countries for so long. It's just that, the issues didn't reach our shores, so to speak. Yeah. But the COVID-19 really brought the misery of the millions of people, brought it actually home, and I'm not saying it in a gloating way, but it actually made everybody feel what it looks like when you don't have a ventilator machine, you don't have a mask equipment, you don't have this or you don't have that. So I really think we have to go back to fundamentals, thinking of health as a health delivery system, like Mary said. It's about the whole cycle being very harmonized together. You still need cancer control plans. You still need strategies. You have to do that hard work. And that's why I think Qatar has done so well. Really, if we want to talk a little bit about Qatar, I am so impressed by the fact that, I know some people might say, oh, but it's a rich country. But you know what? It's not, yes, they did not have the financial barrier. That's great for them. But I really feel they really followed the fundamentals. They really did a stepwise approach in putting strategies for cancer, strategies for immunotherapy, strategies for research. They've done the boring bits, so to speak, to reach where they are. And I think countries we still have to go back to fundamentals. And like Mary said, you have to still deal with prevention. Close cancer, block it at the door. That's still the most cost effective. Do the early detection. Still many people present late and so on and so forth. So if you deal with it in a comprehensive way, in a proper plan and systematically, that is still the case. That's the issue. But all I'm saying is low, middle, and yes, we can think about immunotherapy because we don't want that big gap to be even bigger. But we still need a leg up. Low, middle income countries still need a leg up with the same thinking of solidarity that we saw with COVID. And I think that has to be really spoken about clearly.
So in the report, Professor Griffiths, one of the key evidence-based recommendations it's made is to say that we need to create frameworks for the use of observational data. Why aren't the frameworks all in place now? Is it because it's such a young therapy?
I think that it's a good question, and I don't absolutely know the answers, but I think it's all about you taking advantage of the shift in culture that we're seeing now, where there's much better communication, where you can integrate a lot of data that is perhaps not being made use of at the moment. And so I think I think in answer to the question that was posed was there needs to be a shift in the culture, and policymakers and governments really need to make sure that they come up with a national framework that is harmonized with those of other countries, because otherwise they're going to lose out. And I think there needs to be a more greater sort of global collaboration in all of this. And I think that's one of the aims that we've come up with. I can see Dr. Oram raising his hand.
Yes, I'd like to bring Dr. Oram in on that, please.
Yes. So actually, to add to what Professor Griffith has just said, globalization of data means that we should be using similar standards. And if we use similar standards, actually, we can get quite a lot of data from even the developing countries. And that means they can contribute to the body of data that we have that can be analyzed. And within a very short time, you can actually be able to answer big questions. So I think that is really a very, very important point about us seeing how we can actually bring information together. And that means we need to be using similar standards.
Professor Gospodarovich, you want to come in on that?
Right, the data is very important. There's a power in information. But in medicine and in healthcare, data is being taken for granted. I sort of look at my hospital and I think, how many people are looking after financial data? How many people, make sure that the data is correct? They steward the data before they analyze it. And yet, when we talk about healthcare data, people sort of hope that they'll go to medical records, get the data. There's no need for stewardship. There's no need for management of the data. So the medical data, healthcare data need investment, a conscious investment in the quality and the size of the data. And then I think the progress could be scaled up and accelerated much faster because we can learn from every patient all around the world.
Ian Fowkes, on that question of data, globalizing the data.
Yeah, I mean, it's a critical piece. I mean, even in countries like the UK, I mean, we don't have some of those standard approaches in place. So, we do clinical trials differently even here. So I think it's vital that we get some agreement, international agreement on these data policies. I think we also then need to have a conversation with the public about the use of data and the use of their data. There's incredibly stringent regulations around how data is used at the moment and how it's sort of moved around the country and then across international borders, and rightly so. I think our data is important, but if we want to see the gains that science can bring for medicine and health, I think we need to think differently about how our data is used. We're quite happy for Facebook and Twitter and everyone else to sort of put all sorts of data on there. I've not met a cancer patient yet that has said they don't want their data used to further treatment. But the regulations at the moment don't necessarily facilitate that. So I think we've got to have a bit of a grown-up conversation with the public as well as the system.
That is such a good point, about Facebook and Twitter and putting ourselves out there. And the point about the data was the data for this presumably could be anonymized. And I wonder, Gillian Griffiths, who could lead the way on that in a global sense? Because it does need somebody to take the reins. Bill Gates can't do everything.
That's a very good question. I mean, ideally, it would be governments who encourage through public education the idea that we've all got to engage if we all want to speed things along. And whether, again, that requires harmonization and conversations, grown-up conversations between different governments and so on. I mean, I suppose we could have another Bill Gates type person, but I think it needs to be done more centrally. Maybe WHO is a good place to start, actually. They've done a lot so far in bringing together harmonized clinical trials. And so the key there is to get everybody at every level in every place listening to them. And so it's really about communication. In fact, the media has a great role to play in this and has played an important role already. And so I think maybe that's where we need to aim our messages.
Dr. Oram, where do you think the WHO could be a perfect vehicle for that?
Yes, I do think so. But, the WHO cannot work in isolation if the governments are not educated or are not in line with what the scientists are thinking. So to me, I think actually the governments are very important in as far as this is concerned. They must actually understand that data is actually a very big resource. So to me, I think once they understand that, and then WHO can take stewardship, knowing that there is support from respective governments for this type of initiative.
Yes, Your Highness.
Yeah, and I want to second what Professor Jackson said. I mean, governments should realize, especially governments who hardly have any oncologists, not even any oncology personnel in many countries, or not enough, so to speak, that they have to take. They have to support and facilitate the infrastructure for research, because then they will be able to lure back all their nationals who are working, all the brains who are working in the US or Europe or Canada, etc. When my son was being treated, I saw so many doctors that were Jordanians, Lebanese, Palestinians, who were not in Jordan, simply because they felt they could not come back and continue on the career ladder if they are at an institution that doesn't continue research and publication and so on. So when our center promised that they will deliver on that, we went from 4 full-time oncologists to over 200 plus oncologists and consultants, all coming back to be in Jordan. So governments need to understand that as well. And it's so, instead of other countries benefiting from the education that low and middle income countries invested in those people to reach where they are, only to be taken by high income countries. Research is very important for those medical professionals and scientists to come back and serve their country.
Well, it's interesting because all the questions that have been coming in have been on this whole question, Professor Griffiths, of collaboration. So in a way, I do want to finish the session with each of you, as it were, giving an advert for the benefits of wide open collaboration. Professor Gosparovich, you first.
Well, working together, you can move faster.
Yeah.
I think that the progress in science, the progress in implementation of discoveries, the progress in clinical research, we know fundamentally that clinical research is a team sport. It's a collaborative sport. We've learned that many, many years ago. Now we just have to scale it up from our closed systems in our own countries to the global research effort.
Dr. Oram, what's your big advert to make the world a better place through immunotherapy?
Well, I think I would say that there is need for bringing round the table the scientists that are found in the developing countries. They are brilliant. They are interested in knowledge. And the only way that it can be done is to recognize them. And that means that we need to make a similar kind of infrastructure, educational programs that fascinates the young people in the developed world also to be available to them. That is where collaboration comes in, and it's very, very key. Because right now,
so I wonder if it's part of that, what you need almost, and I suppose this is for most medicine, but you kind of need an international immunotherapy passport that practitioners, radiotherapists, nurses, oncologists can move freely around the world to add to their knowledge.
Absolutely. Actually, that's the point.
Thank you very much indeed. Ian Fowkes.
Yeah, well, I think echoing what's partly been said, collaboration, I think it really is the sort of fuel for scientific progress. And I know we're all getting fed up with platforms like Teams and everything else, but it does allow us to speak across continents very quickly and very readily. You know, and I do really hope that one of the things that comes out of this COVID crisis is our ability to collaborate more easily, because, you know, history shows us that's what makes progress.
And Your Royal Highness, just a quick word.
Yeah, I mean, collaboration is, you know, you need our genes, you need our genetics. We have wonderful T cells as well. It's a win-win situation. So you need to, you know, it enriches your research. You learn from us and we learn from you. It's not
Professor
just a one-one situation. Our T cells.
Professor Griffiths, this report should go around the world, yes?
Absolutely, yes. And I think, you know, what I'm going to plug again is what we want is better public appreciation and government scientific knowledge, so that everyone can appreciate the excitement of the research, the new breakthroughs that come through, and hopefully I would like to inspire the next generation of scientists who will be able to go from discovery to development to delivery much more seamlessly than is currently possible. Thank you.
But at this stage, I'd like to thank you very much for your participation. I'm very sorry for some of the technical errors we had, but we are doing our best. Thank you very much for joining us.
Thank
you.